Welcome to My Breastie Says, two friends exploring life during and after breast cancer from two totally different perspectives. I'm Chris, a breast cancer survivor and a mother of two.
I'm Jenni, a physical therapist and medical professional who specializes in breast cancer care. Together, we created this podcast to bring both sides of the story, the medical insight and the lived experience.
What is natural? When you read natural flavors on a label, most people don't realize it's often not real food at all. Those hidden ingredients quietly work against how your body feels and functions over time. That's why Just Ingredients uses only real food ingredients, so you know exactly what you're putting in your body. Stop guessing. Start knowing at justingredients.us.
New CBS Sunday.
The Grammys, baby! History will be made.
Live, unfiltered, unexpected. Bigger than ever.
I was a ghost.
Bigger stars, bigger performances. Music's biggest night is getting bigger.
Now you see what all the hype is about.
Trevor Noah hosts the Grammy Awards live.
Anything is possible.
CBS Sunday and streaming on Paramount Plus.
Not every summer we meet for a trip.
Vacation has officially begun on Netflix.
To best enjoy your trip, we suggest the following itinerary.
I say we just wing it.
Wing it.
See where the wind takes us.
From best-selling author Emily Henry
Are you guys like a thing?
Oh, no,
we're
we're
just
just friends. Platonic travel companions.
comes your next favorite rom-com.
Who wants to go skinny dipping?
Alex does.
Vacation Alex!
I love it when you get weird.
People We Meet on Vacation, now playing on Netflix. Rated PG-13. May be inappropriate for children under 13.
REI Co-op knows when you're up at 4:30 a.m. on a Saturday for a long run and you're actually excited, not everyone gets it, but we do. At REI, we're here for people who get outside. Gear up for your next run in-store or at rei.com.
I'm so excited for today's episode. We have with us Paige Woodward. She is a nurse practitioner, Yale trained, mind you, with over 20 years experience in oncology. She's worked at Dana-Farber. She's worked at Cedars-Sinai. She is one smart cookie. She also knows functional medicine, which is incredible because not a lot of people in the oncology space do. And she's one of my dear besties. Paige, welcome to the show.
And she was my nurse
Woo-hoo.
practitioner. So yay, we
So much
having
love
you.
for Paige. And we have a lot of questions today about GLP1s, and we were hoping you could give us some basic info.
I'd be happy to talk about that. And thank you guys for having me back again. And I love what you guys are doing with the podcast. I love listening to it on my car rides.
Okay.
So GLP1s, everybody knows about them as the weight loss drugs or the diabetes drugs. They were originally developed for type 2 diabetes. They now work their way into the weight loss space, and now they're being looked at in cancer. So I'm going to backtrack and just talk to you about what GLP1s are. So they're glucagon-like peptides, and they are agonists. So they help with insulin resistance. They help decrease appetite. They slow gastric emptying, meaning when you eat and you feel full, it slows down the food going through your digestive tract so that you're not wanting to keep eating. And they can help bring the blood sugar down. So if you get your labs and you get a comprehensive metabolic panel, it'll show you your glucose level. So we want to keep that lower. And if you're a diabetic or as we age, they start looking at hemoglobin A1C, which is a measure of your glucose over the last 3 months. And diabetes now is considered a hemoglobin A1C of 5.8 or higher. These medications help lower that level as well.
But have they been used? Have they've been used for a long time in diabetes? This is kind of like a tried and true diabetes drugs, meaning
Yes.
to hit the mark. Okay.
Yes, I think the first GLP drugs were developed back in, I want to say, the early 2000s, 2005, 2006. And then I think semaglutide, which is the brand name is Ozempic or Wegovy. People usually know those. I've seen all the ads.
Yeah.
That one. Yes. Ozempic.
Yeah.
Now I'm going to sing that in my head. That came to market, I want to say around 2016, 2017. And then now there's a dual agonist, which is a GLP-GIP, and that is tirzepatide, or the brand names are Zepbound and Mounjaro. And Mounjaro is for diabetes, Zepbound is for weight loss.
And what's that mean, dual agonist?
So it targets the glucagon peptide and the what's the other one?
I don't actually know what that means. So does it do like extra things than Ozempic does? Okay.
Yeah, it targets like two different, it's like the GIP is, I think the glucagon something, I forget.
That's
anyway,
fine.
and
No
now
one
there's
knows
a
what
new
those are.
one coming to market that's a triple agonist. So it targets like the GLP, the GIP, and something else. And it's called, yes.
Oh, nice.
And
Yes.
I'm living with my son who knows everything about all this. I think he's going into your field, Paige. Who knows? But the question I have as a breast cancer survivor, is it safe? What are because everyone's on it. You see all those celebrities out in LA, and everybody's skinny now. Just for being skinny. And I know that when I was going through cancer, I went to see a nutritionist, and she was like, look, the leaner you are, the better it is for not to have reoccurrence. So that makes me think getting off that extra weight is healthy. What is your thoughts on it? I know that it's not concrete yet, but like, what do you think as an expert in this area?
absolutely. Breast cancer, especially if you're estrogen positive, a lot fat cells have estrogen in them. And so the more weight you carry, the more estrogen you have circulating in your body. So yes, they've found that decreasing the amount of fat that you carry around, it's just healthy for all your organs. But yes, it decreases your recurrence risk. And all the patients, even people who are triple negative, meaning they don't carry the estrogen receptor positive, we throw them into menopause with these medications, which causes people to gain weight, especially around the midsection.
Are you talking about like chemo agents and all that
Chemo,
stuff?
if you're estrogen positive, a lot of people have to take anti-hormonal therapy. So that would be like the tamoxifens or an aromatase inhibitor like anastrozole, exemestane, letrozole. And those medications shut down estrogen even more. And you're like, people are gaining weight and they're feeling inflamed and they have joint pain. And these GLP-1s have shown not only do they help with weight loss and control like blood sugar, but they're also decreasing inflammation and helping reset the metabolic profile. And so
when you say, sorry to interrupt, when you say inflammation metabolic profile, that just means like the inflammation in your body that, for example, could make your joints feel painful or could that kind of a thing. Okay.
And again, so going back to if you're heavier, it's also, you're putting more stress on your joint. And then you're in menopause, or we've thrown you into menopause, and then you're gaining weight. It's like this drug can have a lot of benefits for that. And it's not FDA approved, but people are microdosing these medications, meaning they're taking a lesser dose than the standard starting dose. So like for tirzepatide, which is Mounjaro or Zepbound, it's 2.5 milligrams a week injected, and people are doing maybe 1 milligram or 1.25 milligrams, and they're seeing significant effects.
Sorry to interrupt too, but I have friends that are doing whatever you said, like the very lowest one, but like once a month, that's it, just to maintain whatever they've lost and make because their body feels better. But then there's also the question of, because it isn't FDA approved, has this been around a long time? I know you said 2017, but I don't know. It's scary for me being a cancer survivor too, like taking that leap. Is there
do you feel comfortable, Paige, prescribing it to your cancer patients? And if so,
I definitely would, obviously you need to assess the individual and make sure I wouldn't put someone who's had like a eating disorder history on one of these. If there's a type of thyroid cancer that, they saw it in rats. They haven't really translated that to humans, but if you do have that history of a certain type of thyroid cancer, like you can't go on those. But I think in general, they're safe. Like any medication, there's side effects. And I think the horrible stories we hear about these are because people are dosing way too high, too frequently, not being managed by a medical professional. I do think that they have a lot of benefits for cancer patients. And I can talk about some studies that they've been doing where they've seen some benefits, and they're running them in clinical trials now
Please
too.
do. I love hearing the studies. So if you have them, go for it.
Sure. So the San Antonio Breast Cancer Conference, that is every year. It's a big breast cancer conference, and the 2025 one was held in December. And they had a bunch of abstracts that they presented in different aspects of breast cancer and using GLP1s. And a lot of it was retrospective data, meaning they went back and looked back at patient data and people were on these drugs. They weren't like, now they're actively recruiting people in clinical trials, but
just for our non research people. Yeah. So retrospective is not like the highest level of study of research, correct?
Right.
Okay.
It's basically they can pull data from some data source, maybe within their own health system, and they can look back at and factor in different things and pull the data and kind of look. And so one of the big studies that I thought was really awesome that came out of San Antonio or abstracts, is they looked at women who are actively on chemotherapy for breast cancer. So I'm sure you've heard of the Red Devil, adriamycin, Cytoxan, or TCHP.
I've definitely heard of it.
Because you went through it.
Yeah, you might have put it in my little port.
Yeah. So they looked at this retrospective study. I want to say it was like 5,000 women, and women who were on GLP-1s, either for weight loss or for diabetes, did far better and had far less side effects on the chemotherapy than women who were not on them. Yes, it was pretty incredible. Like,
wait, less side effects?
Yes.
As opposed to, does it help with the nausea? Did it help with, what were the side effects?
I can tell you.
That's huge.
So they saw lower rates of neutropenia, which is lower the white blood cells. Neutropenia is when your neutrophils, which is a part of the white blood cell that helps fight infection, gets really low. And a lot of the chemo drugs knock that down. And that can prevent you from staying on schedule. Sometimes we have to give you supportive medications to keep your white blood cells up. So they saw far less of that.
Amazing.
They said, let's see, neuropathy, which... So, for people who don't know what that is, it is when you get nerve basically damage, irritated nerves from taxine drugs, so Taxol, Taxotere, carboplatin, oxaliplatin if you're a colon cancer patient, and people get numbness, tingling, sometimes burning pain. They can get it in their hands, their feet. It can travel up their legs, and it can be very debilitating. And I'm sure Jenni can weigh in on that as a physical therapist.
And it can be hard to treat too. Once you have it, it's not real easy, not always easy.
A lot of times it doesn't go away, and we do physical therapy. There's medications, but those medications come with side effects, and they might just numb the pain. They don't really treat the issue. So they saw less neuropathy, less neutropenia. I want to say, let's see, less nausea, vomiting, fatigue, less interruptions in treatment because people weren't having such severe side effects that we had to delay treatment. So that's really exciting.
That's so powerful, the nausea and vomiting, because that for a cancer patient going through chemo is really big deal. The only thing I wonder and I would worry about is when you're going through chemo, you're not really eating a lot as well, and you're losing weight. It depends, right? Because sometimes you're on the steroids that make you want to ravish everything.
Right.
My treatment, I didn't have to be on the steroids. So I was doing it once a week, but you lose weight. I lost a lot of weight on chemo. I wonder, pairing that with the GLP-1, is that okay?
So that is a concern because it does decrease appetite, and it slows, as I was talking about gastric emptying, slowing the food going through your GI tract. And you need your nutrition, especially while going through cancer. You need protein, you need healthy fats, you need to hydrate. I think that's something that needs to be addressed. So maybe it's a low dose, unless they're already managed for weight loss. They're already stabilized on the drug for weight loss or diabetes. But I think if we put people on these, we start very low and go slow. That is a concern. And being on a GLP-1 doesn't mean that you get to eat like crap. It means that you need to be really protein focused because you can muscle waste, and you need to work out. And so that's another issue when people are going through chemo, they feel crappy. And sometimes just to get off the couch and go for a walk is a lot. It sounds like from this retrospective study, people had less fatigue and felt better. So maybe that would prompt them to want to
more
exercise more.
With
Get
that,
out of the house.
with that study or any of the studies in San Antonio, did they find anything that said the chemo was more effective? It was better at attacking the cancer cells, or more just what you were talking about?
I think this particular one was that it reduced the treatment-related side effects and toxicities. There was a bunch of abstracts. One of the other ones that they're looking at it, that it may actually reduce like tumor recurrence. So they do it in colon cancer. They use it in prostate cancer. Signatera test. It's basically looking at circulating ctDNA, circulating tumor DNA, and they can see if there's any like microscopic cells still floating around. And there was another study that looked at possibly the GLP1's decrease the circulating tumor cells.
That's great.
So,
That's insane.
Wow.
Yeah.
So good. I also hear a lot that the semaglutide, which is like the Ozempic, right, versus the Mounjaro. What is the Mounjaro called?
That's tirzepatide. That's a dual agonist, and semaglutide is a single agonist.
And so the single agonist I heard is more nausea or kind of the symptoms of that. But the other one, people don't get that side effect.
That's what I've heard too, and listening to podcasts and reading stuff from endocrinologists who specialize in this. They've said that they tend to see less nausea with the dual agonist.
Yeah.
I don't know. I think there's a place, and again, it has to be an individual assessment to see if people are candidates for this, but I was really excited about that.
Can I ask, why would you prescribe the dual agonist versus the single agonist first? Like, how would you decide when working with a patient?
Sometimes it's insurance dependent if they're a candidate for insurance to cover this, because they're expensive drugs. There's really good data with semaglutide, I think, in cardiac, reducing like cardiac numbers and cardiac risk.
Right.
But I don't know. I like the dual agonist because I think it targets more things.
That makes sense.
Semaglutide was the original one or there's multiple drugs, but like the big one that became like a big household name, and they're just developing more. And I don't know. I would probably go for the tirzepatide, the dual, if you can with it. But if it's appropriate.
When is the retatrutide coming out? Do you know?
I am not sure, but they just published the phase 3 data on it, and it had phenomenal like data on weight loss and like managing like insulin resistance and diabetes. And so I feel you can get it on the black market. Again, people have been buying some of these like retatrutide you can get from companies that sell direct to consumer, and they're not tested. I don't recommend that at all, because you have no idea what's in these. You don't know if they've been third-party tested. And the issue too is they tried to block compounding pharmacies from making these drugs. So it's like you have to kind of get them from
I think we just wait.
Yeah.
Be patient, and we are grateful that we have the two that are already FDA approved.
Now we have the pill form. Didn't one of them come out in the pill? Is that on the market? Do you know?
Yes, it just came out on the market. I believe it's a semaglutide pill. And it has decent data of injections or in terms of like weight loss and the different things they look at. It's not as good as the injectables. I think, again, I'm not an endocrinologist and an expert, but I think I'm just fascinated by the role they're looking at in cancer. And there was another study too that just got published out of UC San Diego, not for breast cancer, but colorectal cancer. And they looked at data across like the whole UC health system. It was retrospective, meaning they went back and looked at patient data, and they saw like a significant reduction in colon cancer.
Amazing.
Wow.
So
wait, of first-time diagnosis or recurrence?
I don't know. They just looked back and they said that people that were taking these drugs had a reduction.
It probably must, I would imagine, then like first initial diagnosis.
Yeah.
Amazing.
So I feel like there's going to be a role in a bunch of different types of cancer, and especially like endometrial cancer is more of an obesity-driven cancer. So I feel like there's going to be a role for that. And then, there was another study too published I think recently about colorectal cancer, and they saw that GLP-1s decrease the risk of colorectal cancer far more than aspirin, people who are taking aspirin. Because I think it decreases the inflammation.
Wow. Before we let you go, this sounds like it's a wonder drug, right? But I'm sure there are side effects or risks involved. Could we just touch upon some of those?
People get nervous because they think they're going to be nauseous, they're going to vomit. And the reason they would have that is because it slows down the digestion of food and people get full really fast. So there is that risk of nausea. There's been a couple people that have developed like pancreatitis, which is like inflammation of the pancreas and elevated pancreatic enzymes like amylase and lipase. So we need to monitor for that. But again, I feel like people get into less trouble if they're monitored closely. You start at a low dose. Like for tirzepatide, it says to start at the 2.5 milligram dose if you start on standard dosing, and you have to be on that for at least 4 weeks, and you shouldn't just increase it. And if someone's tolerating it and not having significant side effects and they're having good response to it, then leave them at that. And I think some people that prescribe these think, oh, okay, we did the 4 weeks, we need to increase the dose. And then people get maxed out on it. And I feel like that's been a lot of side effects. Some people are just more sensitive. Maybe they have an allergic reaction to something that's in the medication.
Well, on a vanity side note, I feel like when people level up so quick and they lose this weight so quick, that's causing all the sagging of the skin. Like you gotta be patient with that. Otherwise you're gonna you're gonna age yourself a little.
It's that. And like I said, you also need to make sure you're eating properly. This isn't a pass to go eat like candy and junk. This is, no, your nutrition still needs to be a focus of eating veggies, protein, and also for exercising. Because there's a lot of people who are like, oh, I'm losing weight. This is great. And
But
then they decide they're
too,
going to
right?
exercise. But I'm like, you're losing muscle. Yeah, you're muscle wasting.
So one final question, then, is this something you have to stay on indefinitely to maintain the results?
So in terms of cancer, I don't know, because
There's not
there's not the data, and they're looking at them in clinical trials. They're doing active clinical trials. You can look on like the NIH, National Institutes of Health, or clinicaltrials.gov to find places that are running these if you're interested. But in terms of staying on them, they have shown that people who do come off them can have rebound weight gain. So they're trying to look at, as Chris was talking about, people do the like monthly injections. Like that's not in the FDA guidelines of how to use these drugs, but sometimes people are doing like an injection once every 2 weeks, once a month, just maintain.
And it's probably hard to know too, like in that study where everybody, the weight came back, were these also the people who were like, I'm just going to eat junk food and not exercise and lose all the weight? And then once they're off it, they haven't changed any habits, right? There's
probably some of that. I know Oprah, because everybody knows who Oprah is. She was on one of the GLPs, and then she stopped for a while, and she was very candid about how she had rebound weight gain. But again, I don't know what people's lifestyle habits.
Right. You know what? I feel like with that retatrutide, the 3 one, I feel like some research, and I could be totally wrong, but I felt like it said something where that one is less likely to attack the muscle.
Oh, interesting.
Yeah,
I could be wrong there, so don't hold me to it, to the listeners. But that's what I thought one of the positives were for that one coming out. But I don't know.
And one other caveat I was going to say about the GLP-1s, they've shown that they can help decrease like alcohol use and people who have like addiction issues. Wow. And I think that's really important to mention in terms of cancer, because they've shown alcohol is a very high risk for recurrence or developing cancer. It's connected to 9 different types of cancer. So I think that could be another positive, that it decreases people's urge to want to drink.
I did hear that too.
So I think that could be another good benefit. But again, you need to be managed properly and monitored closely.
I wonder if they're going to start using it, or if they're already using it in different rehabs for that.
Yeah.
I feel like there's going to be a lot more research that's going to come out looking at it in different aspects of healthcare.
And once some of that's published, we'll have you back on to update us.
Sounds good.
And Paige, where can our listeners find you?
So you can follow me at Functional Cancer Care on Instagram. I also have a separate integrative practice called Vibrant Integrative Health, and I'm licensed in California, Massachusetts, and New Hampshire. So if you're interested in looking at a GLP-1 or you're interested in like hormone therapy, if you're a candidate for it, I can do that in those states.
Oh, yay. Thank you so much.
Well, I'm booking an appointment to talk about hormone therapy. Oh my gosh. Okay, great.
Thanks so much,
For coming.
Paige.
You're
See you
welcome.
soon.
Bye.
Bye.